Good evening, everybody, and welcome to tonight's OBI Public Talk, Innovative Treatments in Brain Health. This is our 40th public talk, and we are very proud to celebrate this milestone with you. My name is Bryce Pickard, and I'm the Chief Operating Officer and President at the Ontario Brain Institute. Before we begin, I'd like to acknowledge that we are gathered in Tikaronto, the Indigenous name for Toronto, meaning the place in the water where the trees are standing. We are on the traditional territories of many Indigenous nations, including the Mississauga of the Credit, the Anishinaabeg, the Chippewa, the Haudenosaunee, and the Wendat people. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples. We are grateful to live, work, and learn here, and we affirm our responsibility to engage in the spirit of reconciliation. As an organization focused on brain health, OBI continues to learn from Indigenous knowledge systems, especially their holistic view of well-being, which considers the deep connection between mind, body, and spirit. Our 2025-26 series, Breakthroughs in Brain Science, celebrates OBI's impact on Ontario's neuroscience landscape. Tonight, we are focusing on a pillar of health that is often felt, but not often seen, mental health. At OBI, we view mental health as a fundamental aspect of overall brain health. It is the very thing that allows us to be truly present with our family and friends, to engage in meaningfully productive work, and to maintain the resilience needed to overcome life's inevitable challenges. However, we know that the weight of this challenge is significant. The Ontario government has noted that the burden of mental health and addictions is more than 1.5 times the burden of all cancers combined, and that roughly 1 in 10 Ontarians experience a mental health or substance use challenge in any given year. OBI is helping to address these concerns on many fronts. Through our unique team science model, we are addressing these issues via cutting-edge research that uncovers the biological roots of mood disorders, neurotech innovations that provide new ways to monitor and treat symptoms, and community supports that ensure science translates into better care for the 1 in 3 Ontarians living with a brain disorder. These investments are paying off. As we will see here today, the mental health treatments currently being developed and tested right here in Ontario are poised to change the landscape of care in our province and quite possibly the world. I hope you had a chance to visit the exhibitor booths to see some of the work happening by our partners here in Ontario, including the release of the Choice D patient-friendly family guidelines for the treatment and management of depression developed by CanBind, one of OBI's research programs. And now I would like to introduce tonight's moderator, Dr. Krishana Sankar, a molecular and cell biologist with a PhD from the University of Toronto. Krishana is a researcher and a science communicator passionate about dispelling health and science misconceptions in person and on social media. Welcome, Krishana.
Thank you for that introduction, Bryce. And hello, everyone, and welcome again to tonight's talk, Innovative Treatments in Brain Health. As moderator, I'll facilitate a 35 to 40-minute discussion with our panelists, followed by a chance to hear from you, our audience, through audience questions. We want this to be a true conversation. So for our online viewers, please submit your questions through the chat box on your screen. For those here with us in person, you can simply raise your hand for our volunteers who can provide you with pencil and paper. Or you can submit your question by scanning the QR code that we'll be displaying on the screen. Tonight, we're exploring how Ontario is pioneering a new era for mental health. But as we talk about innovation, we must acknowledge why it's so urgent. For many Ontarians, the reality of mental health challenges is found in the daily struggle to navigate complex systems, the weight of a diagnosis, and the exhaustion of trying treatments that don't always work. We know that managing a condition isn't always enough. People are looking for a path back to themselves. That is where the hope of tonight's discussion lies. We are moving from management to true innovation. Our panelists represent the full pipeline of that hope, from university labs uncovering the biological why behind these struggles, to companies deploying real-world neurotech and clinical solutions that meet people where they're at. We will try to keep the language accessible. All acronyms used will be spelled out with a definition on a slide that will appear on your screen. None of this could happen without the Ontario Brain Institute's unique ecosystem. You can think of it as the province's innovation engine for brain health. By integrating deep research with cutting-edge technology and, most importantly, community insights, OBI has the know-how to turn complex data into breakthrough treatments. These advancements are designed to detect, diagnose, and treat the challenges that affect so many of us, creating a future where personalized care isn't just a distant goal, but a reality for every Ontarian. Before I introduce our panel and begin our discussion tonight, we would like to ask you, our audience, both here in person and online, how do you define mental health? In just one or a few words. So we have a Slido survey link and a QR code that will pop up on the screen where you can type in your response. We'll keep this survey open for just a minute or two, so please add your thoughts there. For any folks that might have some challenges, we also have a printed copy of the QR code circulating. So take a moment or two to add your thoughts, give that definition of what mental health means to you. Now, to introduce our panelists. First up, we have Dr. Rudolf Uher. Dr. Uher, please come to the stage. Dr. Uher is a psychiatrist and Canada Research Chair in Early Intervention in Psychiatry at Dalhousie University, who leads the CanBind's OPTIMUM-D biomarker-based clinical trial. Let's give a round of applause. Next, we have Anne Wilson. Anne, please come to the stage. Anne is a registered social worker and program manager of the Toronto Transitional Age Youth Program at Loft Community Services. And last but not least, Dr. Jonathan Downar. Dr. Downar is an adjunct professor in the Department of Psychiatry and Institute of Medical Sciences at the University of Toronto, who specializes in TMS for the treatment of mental health conditions. Thank you for joining me. So these experts are taking us beyond what was once thought possible in brain health. So before we dive in, let's take a look at these Slido results. Let's see, will they come up? Awesome. Okay, so I'm going to dive into the Slido results. The question was, how would you define mental health? I believe the results should be brought up on your screens. We're seeing there's well-being, thriving, some interesting words here as well, complex, flourishing, self-positivity, stability, unpredictable, holistic, and essential. The well-being and thriving, though, those two in particular are really highlighted. So thank you so much, everyone, for sharing your thoughts on how you would define mental health. Okay, so to start us off, how would each of you, our panelists today, define mental health? So the WHO defines it as a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. So how close does this definition mirror your own view on mental health? And Rudolf, I will start with you.
Oh, okay. There's a lot in it already, but when I think about mental health, I see it as the functional side of it, as being able to do what's important for you and feel good about it. For someone, it's study, work, family, all those important things in life. That's mental health for me.
Great, thank you so much. Anne?
First, hello everyone. When I think of mental health, I always look at the person in the community. Because the state of one's mental well-being, it's interdependent and a part of a larger whole. So when we're asking about mental health, we also should be asking, how are we defining and designing flourishing and thriving communities so that it contributes to the well-being of people? We think about relational supports, the strength of connected care in communities, and I think that's how we would define mental health.
Awesome. Thank you for that. And flourishing was one of the words that folks used in the definition of mental health. Jonathan, what about you?
So I think it's really nice to hear in the responses from everybody and on stage here the elements that health is a lot more than just the absence of illness, but that involves flourishing. And I think it's really important to emphasize that a community is essential behind that. So if I could add one other piece, it would really be like a lot of the patients who I speak to when they recover health, what they tend to talk a lot about is resilience. They talk about the ability to regain the capacity to bounce back from setbacks, to not be overwhelmed by things, and to be resilient to the stresses that life is just going to throw at you every day. And so that resilience piece, I think, is also really essential.
Yes, thank you so much for that. So now that we have a better definition of what mental health means to our panelists, let's dive into how each of you are supporting mental health in different ways. So Rudolf, depression is notoriously difficult to treat because what works for one person oftentimes fails for another. How is your work with biomarkers helping us move away from this trial and error approach and toward a more predictable way of getting people well? And also, I might ask, can you define what biomarkers are?
I'll try to remember all of that. Yes. So, look, out of all the health problems, the one that keeps most Canadians out of work or study or completing things is depression. And it's still one. It was 10 years ago. It is still depression now, which when you think of it, is really a problem, because it's not like we don't have treatments. I grabbed the Choice D guide on the way here from our combined booth here. So that's the plain language explanation of all the treatments for depression, and I counted 3 dozens of treatments. And each one of these treatments is effective for some people and available to many. And yet we don't have any fewer people with depression. So big reason for this is a person may try a treatment but will not get the treatment that will work for them. And what we doing in Canbind is mapping the person's own depression landscape to make a better estimate, to predict which treatment will work for this particular person, with the aim to just get more people better, faster, so they can resume what they need to do. And what is a biomarker? Biomarker is something that's biological, right? That's to do with our body, not just with a response on a questionnaire. But beyond that, it's quite a broad concept. So a biomarker may be a blood test, something that's measured in your blood. But biomarker can also be brain function measured with an electrode or with a scanner. And biomarker can also be a pattern of activity and breathing and heart rate measured with smartwatch, right? So quite a broad concept. One of the biomarkers we using is speech, recording of speech, and that's certainly biological, but it's not just biological, right? Speech is also something we learn and how we connect with others. But they are all objective measurements that really take us far beyond just having responses on questionnaires or interviews, and that add objectivity towards choosing treatment for people.
Great. Thank you so much for that, Rudolf. Jonathan, you have often framed our current mental health crisis not just as a medical problem, but also as a failure of technology and economics. Could you start by explaining what TMS is and why we need to treat depression as both a medical and a technological challenge?
Sure, absolutely. TMS, transcranial, through the cranium, magnetic stimulation. So a technology for stimulating specific circuits within the brain, not using electrodes or surgery, but just using harmless magnetic field pulses that can activate the neurons or the brain cells in specific circuits. What circuits to stimulate? Well, we talked earlier about resilience. Some people, as we know, have tremendous amounts of natural resilience. There are many people who have been through incredible amounts of trauma and strife in their life, and somehow they just seem to be able to keep going. They be able to bounce back. When we work with people in therapy, we try and instill them with this ability to have resilience and bounce back from setbacks. Are there circuits that do that? Yeah, there are. There are specific regions of the brain where some people actually have more gray matter there, and those people are much more likely to be able to get through childhood trauma and somehow never develop depression or PTSD or whatever. Interestingly, when you look at the brain scans of thousands of people who have various mental health conditions, across all conditions, it turns out that there are some common elements. The very same circuits that are bulked up in people with high resilience are often tend to be thinned out a little bit in people with less resilience. And those are the same areas we activate when we do things like DBT and CBT and mindfulness and so on. Could we do an artificial version of that? Could we give those circuits an exercise program? Transcranial magnetic stimulation delivers hundreds of pulses to strengthen these circuits and build up their connections. You do that session after session after session. It's a little bit like an exercise program that can strengthen people's activity. It's been Health Canada approved since 2002, but why hasn't it scaled? Well, the devices up until, I'm holding a little handheld one in my hand here, but if you go to a TMS clinic today, typically it's a room full of gear that costs $250,000 worth, and it's not easy to move around, takes weeks to train up. When we started doing it, it would take about 38 minutes in the chair to do one session. And you'd have to do about 30 sessions to get better. So that's not many people, especially in rural areas, are going to come into the clinic 30 times for 38 minutes in the chair. It's 111 hours of work to get one person better from depression. So it just doesn't scale. The technology piece, we're all familiar with this. Molecules, you discover a new molecule like Prozac or the SSRIs that we have today are not better molecules than they were in 1985. If psychedelics ever take off and become mainstream treatments, those molecules won't be better in 40 years than they are now. The molecules stay the molecules. Technologies are different, though. You can fiddle with them. You can make them better. If you bought an electric car in 1997, it was probably terrible. But over time, you can tweak it and fiddle with it until they actually become less expensive and more capable. Solar panels, lithium batteries, wind turbines, all of these things. TMS is the same. So we are trying to get the economics of TMS to be small little handheld devices that are on par with the expense of TMS or with medications, and the treatment program down from 8 weeks down to about 8 hours to complete a session. Something you can do in a single day.
Oh, wow. From 8 weeks to 8 hours. That's amazing. Thank you for sharing that. Anne, you've been working on the front lines to adapt clinical standards like dialectical behavior therapy, DBT, to better serve diverse youth populations. Could you explain how this has been adapted to be more effective for the young people that you serve?
So our team has been implementing a dialectical behavior therapy skills group for youth, 16 to 29 years old. And it's been very successful. We see youth learning the skills in mindfulness, managing intense emotions, and creating and maintaining relationships, positive relationships. But we took a pause and we asked ourselves, we understand that DBT in itself has developed with largely a more Western context. And we are serving youth from diverse communities, youth coming from Black, Indigenous, people of color communities. So we have to ask, how might we improve our delivery of DBT so that it becomes more culturally relevant and responsive to the needs of diverse BIPOC youth? And so we looked at being very intentional about this, really creating that cultural lens when we're looking at adapting the core concepts of DBT and making space for discussions with the youth on, Hey, get creative, be curious. How are you practicing mindfulness in your culture? What did you learn about distress tolerance or self soothing in your family? A concrete example is often in DBT, we teach about using cold water to tip the temperature in your body when you're experiencing panic or anxiety. But one of the youth mentioned, I'm not sure about cold water. Because in my culture, I grew up with warm water or hot tea being the more soothing type. And so we encourage that, like bring that in the discussion. We also find the youth mentioning how they navigate some tensions in their family. They understand that for some of them, coming from migrant families, their parents grew up with a different culture, like a first culture. And then they're navigating the Canadian culture, a second culture. And they feel like, we are the third culture kids. We are the one trying to navigate how do we create good relationships in our family, in our friends, and still feel rooted to our parents' culture and to ours. So we are bringing those things in discussion, very intentional, encouraging creativity, bringing curiosity, allowing the youth to even challenge the skills. If it's not going to work for you, then it's not. And that our hope is that we continue that discussion and create more adaptations that fits well or resonates well with them.
Thanks so much for that. So that in particular resonates with me. I don't know, how many of you out in the audience prefer a hot beverage versus going into like a cold plunge? Any hands? Hot? Cold? Okay, no. Okay, good to know. Just pulling you folks. All right, thanks for that, Anne. And now turning back to you, Rudolf. Going back to personalized medicine. So, personalized medicine sounds really ideal, right? But there's a concern that these biomarker approaches will only be available to the elite academic centers. How close are we to making this a reality for the average Canadian patient? And what are you doing to ensure this isn't just a luxury treatment?
Yes. So first of all, this is something that's being tested, and there's a bit of story behind it, right? When we did treatment, we treated 200 people with depression and combined. We found many of them needed a second treatment added to get better, but we also found out we could predict who will need it. And then the question came, well, if you can predict it ahead of time, why to wait 8 weeks to fail a treatment? It's frustrating, it's dangerous. Why don't you give me the treatments I need straight away, right? So that's what we're testing. And the way of predicting it, we could have picked different ways of predicting it, different biomarkers, right? We could go for brain scans, and those would be exactly what you say, right? Unavailable only in the big academic sites, multi-million investment needed to make such a scanner available. So what we actually testing now in OPTIMUM-D is a combination of symptoms and brain activity, but brain activity measured by a portable electroencephalography machine is this size. So, just like what Jonathan is doing with RTMS, making it accessible, portable, it's easy to set up. We are including new community sites, not just big academic sites. And it's fairly easy to implement. It's still investment, but it's investment of thousands, not of millions, to have that measurement going. So, it really will become a question of cost benefit. If it's making enough difference, we'll make it available enough, right? If it's not making enough difference to be worth that investment, we'll go to something else. Something else we're working with is recordings of speech. And that's like 1 minute of speech gives you so much information about depression as a half an hour interview. And that's really easy to do. That's really portable and scalable, right? So we certainly keep that in mind because we don't want to create an ivory tower treatment for a few. We want to create something that will have more people get better faster across Canada, across Ontario, beyond Canada.
Exactly. So scalability is extremely important. And talking about that, Jonathan, you've made a compelling case for scaling mental health care, but we often see a digital divide in Canada. How are you ensuring that your TMS protocol doesn't leave behind folks in rural or remote regions who don't have access to the specialized clinics? And I know you have your prop there. So yes, please go ahead and tell us about
So
that.
this is a really crucial question, whether it's Ontario or Canada. We're a really spread out country. And if we're going to truly talk about things that can help mental health and be scalable solutions, they have to be available to everybody everywhere, not just in specialized sessions. A room-sized pile of apparatus that costs $250,000 is not something you're going to set up everywhere. We just assumed for many years it had to be that way. In 2019, a patient from my TMS clinic back at the Toronto Western Hospital in those days came into his appointment with me one day, and he had actually been flying down to the US to a private clinic to get his treatments and flying back again, and he couldn't afford to keep doing that. So one day I saw him coming down the hallway, and he was dragging this suitcase with him, and he was an electrical engineer. And he actually pulled this device and opened it up and said, "Look, I built my own." And he had built his own TMS device for about $4,000 in power station parts, and he was showing me, and he was in remission for the first time, and he was actually treating himself with this device. So between that and a few other things, we started thinking maybe it was time to improve the hardware a bit. And so thanks to the Ontario Brain Institute funding, we're now building in Mississauga 10 new devices a week that are built for the Canadian situation. They're small. They're portable, they're suitcase size. They also have tiny little cameras on the bottom so you can see where they're being put. You can do telemedicine sessions with them, so they can be shipped literally all over the country to any place. It doesn't have to be a hospital. It can go to an outpatient medical clinic or whatever. And a provider or a physician can log in. We actually did this just the other week with a clinic that was in a completely different time zone. And you can talk to the nurses or the medical staff through doing an entire session. You can see exactly where the camera is going, where the coil is going, and the software inside can make sure that there's no way to, you can literally only put it over the correct location to do the treatments. So this is a telemedicine capable, small, affordable, portable system that was specifically built so it can be sent to every corner of the country.
So is there a timeline for availability of this?
Health Canada approval, I'm hearing April 4th. That's a Sunday, or that's a weekend, so it'll probably be the day or two after that. But I'd hope to have good news by this week. I think it'll be in a week or two.
Oh, wow.
So it's been a 4-year journey, but they're already being built up in Mississauga right now. Again, I guess this is as good a moment as any to say thank you, Ontario Brain Institute, for making this possible.
Yes, thank you so much. The amazing innovations happening, treatments are scaling up, and timelines are going down, which is amazing. Anne, back to you. So you've highlighted that equity in mental health isn't just about speed. I know we're talking about speed and getting things done quickly, but it's also about relevance and cultural safety. So as we move toward more innovative treatments, how do we make sure that clinical innovation doesn't inadvertently overlook the voices and cultural needs of marginalized communities?
When we talk about equity and inclusion, especially in designing community-based services, we really want to be intentional and committed to moving from transactional to something transformative. And for something to be transformative, you have to consciously center the voices of lived experience and the voices of diverse youth. And that means even in the design of the program, we really prioritize having peer support workers or peer support staff because they are trained with skills and competencies, and they also bring their own lived experience. They knew what it's like to struggle with depression or anxiety, to have difficulty navigating the healthcare system. And yet they are overcoming with resiliency, with different supports from multiple disciplinary professionals. So in the groups that we run, it's run by also BIPOC facilitators, the peer support workers has a primary task of being a co-facilitator and really checking in with the youth. When we also talk about equity, it means that we should not shy away from the topics of race, culture, and even systemic injustice. So when we are talking about the skill of radical acceptance as part of the DBT skill, we also ask the youth, reflect with us, how do we bring acceptance over the parts of ourselves that we were conditioned to be ashamed of? And this is especially true for youth coming from Black, Indigenous, and other communities. We look at community building. We find that one of the feedback of the youth is that, oh, I know when I come to the group, I don't have to fear about feeling shame because I know that they get me. When I share about something, about perhaps being bullied in school, or somebody saying, your food's weird, I know that the facilitators, the peer staff, they get me. And I don't have to explain or over-explain my pain. And they also help me find skillful ways of responding or dealing with these stresses and emotions. So I think when we look at equity, again, we look at transformative work. How can we center the voices of the people that we serve, the diverse voices, and that we don't shy away from even the hard questions and making it open to the youth.
And so, Anne, you mentioned that they're the peer co-facilitators, of course, who are youth with lived experience. So they are a pillar of your culture and calm program. So how exactly does the peer support model integrate with clinical care? And why is the lived experience connection so transformative for the youth you serve? I mean, I know you touched on that, but if you can expand on that a bit.
Absolutely. One of the most significant feedback we receive when running the Culture and Calm, it's a 10-week dialectical behavior therapy skills program, came from a youth who we know has complex experiences in navigating the healthcare system. And they mentioned that for the first time, I did not feel like a patient. I felt like a participant. I actually felt like I am among peers. And for us, that's very powerful because that lived connection with peer support staff is a strong humanizing feature of how we do the work. It's a strong humanizing feature wherein you really see the person as they are with their intersectionalities, with their identity. And I think that is very crucial and a pillar of the program. When we talk about facilitating programs, we find that we have to really challenge ourselves in also adapting a together model, a together mindset. Instead of having fragmentation between, oh, these are like the more formal clinical roles and these are like the peer roles with lived experience. Instead of fragmentation, how might we move towards collaboration? Because everyone has a role to play. They might have their own unique competencies, but at the end, they complement each other. And at the end, what is for the best interest of the youth that we're serving?
Great, thank you so much for sharing that, Anne. And so we're just going to zoom out again and go to clinical treatments again. So Jonathan, the idea of completing a full course of treatment in a single day, that still boggles my mind, is very revolutionary. But it sounds, again, almost too good to be true. Is this 1D protocol for everyone? Are there specific types of patients who stand to benefit most? And how do we sort of distinguish, drawing the line between TMS and traditional care?
Let's take it as a two-part question then, as I should explain what the one-day treatment is, and we can go from there. So 1D, the ability to do TMS in a day, not a totally new idea. As early as 2010, a researcher named Paul Holzheimer tried to bring people into a clinic for a day and a half, and he would give them about 15 sessions in a day and a half. About 43% of them improved significantly, like responded to the treatment. And what happened to Discovery in 2010? Nothing. No one did anything with it for 8 years. It's one of those funny things where sometimes some breakthrough almost happens and then doesn't. But the question came up again because we're living in an era right now where this new thing called interventional psychiatry is taking shape alongside our other forms of psychiatry. And in particular, there's a focus on rapid-acting mental health treatments. The first one that everybody knows about, people have heard about ketamine or S-ketamine for depression. It's an old anesthetic that can be used to sort of reset brain circuits. Sometimes brings people out of depression for within hours, but it tends to wear off pretty quickly. People are getting interested in the psychedelics because they might, for some people, not only reset things quickly, but also durably and last for weeks off a single treatment. If that eventually turns out to be true, and we may eventually in a few years have treatments that do this. So the question is, what can TMS do for people in a day? Because patients are coming in saying, well, I don't have 36 days. Well, we have a 5-day accelerated version. Okay, well, I don't have 5 days either. Like I could come for a day, or I'm flying in from the north of the province. I only have a day. What can be done in a day? About 2 years ago, we started looking at this question. You need the sessions to be not 24 hours apart, but about 25 minutes apart. So you can get maybe 20 sessions into a day tops. That's as many as the brain can absorb. 20 sessions, not normally enough sessions to get a full course of TMS. Typically, you'll want 30 or 40. The breakthrough came from University of Calgary, a researcher named Professor Alex McGeer and his colleagues, as well as a team at Harvard named Josh Brown and his colleagues. An old antibiotic called D-cycloserine enhances the brain's plasticity before you do the treatment. It's been used for decades here and there in psychiatry to try and boost the outcomes of therapy. And the outcomes are sort of meh. Like in theory, it should have been awesome. In reality, it didn't do as much as we thought. Until someone paired it with TMS. And when Dr. McGeer and these other folks looked at it, 20 sessions was achieving crazy remission rates 2 or 3 times what the normal success rate would be. And durability also, 2 or 3 times as long. So that's interesting because you can do all the sessions in a day. So the idea was take what Alex had already shown, 20 sessions on D-cycloserine can do quite a lot. Put all the sessions in a single day. Let's see what happens. What happened was the remission rates doubled and the durability lasted longer than traditional TMS. And it now becomes a practical option for people who are coming in from far away, from the north, who have busy lives, potentially for other groups like adolescents and so on. What's interesting is that TMS can treat a lot of different conditions besides depression. It's been around for Parkinson's, and it's even been looked at for things like Alzheimer's and so on. But a lot of these aren't practical if you have to come in 40 times. If you have to only come in once, then that opens up a lot of doors. So that is the potential of the one-day treatment. Who's right for it? There are not that many contraindications to TMS. Most people can do TMS, and I think the best way to think of it is, what would I want for my loved one? What do we all want for our loved one? All 4 of the above. Therapies, medications as appropriate, community-based and social interventions, and brain stimulation treatments are up and coming. If it was my best friend or one of my children or something, I would want all 4 of those things. Up until now, the brain stimulation one has been a bit rationed. It's been a last resort because it either had too many side effects or it was available in too few places or so on. But remember, it's a technology. It can eventually be like smartphones or like solar panels or wind turbines. So the fact that it's end of the line or a treatment of last resort or second last resort now is not the way it's going to have to be forever. Build enough of these, make the protocol safe and scalable enough, and it can be an option alongside all of these treatments for everybody. And I've lost track of the number of patients who told me things like, I've done the DBT program twice, and the first 2 times, it's funny, I know what I'm supposed to do, but when I do it in the moment, it doesn't kick in. What's wrong with me? And then they come and do the TMS, and they say, this is so weird. My DBT works now. Like I can do that. When I do all the techniques, they actually kick in now. So to me, this speaks with the synergy. Like I can't use this device to teach you how to play the guitar or the saxophone or speak Spanish. But if you've done a DBT course and you're one of these people who's frustrated in finding you know what the techniques are intellectually, but when you go to do them, they just don't quite, I'm having a lot of people tell me this. So I would like this to be available for every single person who has therapy as part of their program. I'd like it to just be something you can just have for everyone.
Yeah, that's amazing. I had asked Dr. Downar before our panel started if using TMS could help one become a singer or a dancer. That's a different discussion. So back to you, Rudolf. You mentioned that in your OPTIMUM-D trial, participants are doing better on a 2-drug approach compared to standard care. To someone sitting in the audience, that can sound a bit abstract. What exactly does doing better actually look and feel like?
Yes, and I Thanks, Krishna, but I do not want to overstate because we are halfway. We have 2 years to go before having the final answer. And also, we keep things blinded. We actually don't know at this point who is getting the extra treatment because of the biomarker and who's getting it randomly, right? Because we have to test the biomarker-based treatment indication. Not everyone in the treatment, in the trial, gets the treatment that biomarker indicated. Only half of them do. But when we compared the 200 people that received treatment for depression as part of OPTIMUM-D so far with the 200 people who received treatment in previous combined studies, they're doing better on average. And since half of them are getting exactly the same treatment as they were in the previous study, that doing a bit better can actually mean quite a large benefit for those who are getting the extra treatment because of their biomarkers. But it's a very indirect way of reading into the preliminary data. So, I don't want to be leaving here and suggesting people, oh, you may want to do this EEG, and it's, I think it's worth waiting the two years to have a definite answer and to do it right, so that we do administer medicine in a way that's evidence-based and safe.
Okay, so you don't want to yet say what exactly might doing better look like? Is that, for example, waking up?
I can say that.
Like
yes,
that.
for sure. Yeah. So doing better is it's a scale that asks about symptoms, and the symptom is how have you been feeling over the last week? How have you been sleeping? What was your energy like? What was your concentration like? What were you able to do? What have you been thinking about? Are you still preoccupied with that kind of I'm no good and there's nothing for me in the future? So all that summed up together, right? And then there's 10 questions and it gives you a score, and 30 is a bad depression, below 10 is being well, and the difference between the kind of the starting treatment and end of treatment may be like on average 15, which is pretty good, but about halfway. And the difference we're seeing compared to our previous treatment on average is about 4 points on this scale.
Right. So what does that translate to? So for example, does that mean someone now wakes up feeling a little cheerier today, or is no longer having
it may be a bit different from person to person. What I'm noticing often is people mention, I felt like I wanted to do it. I did not have to push myself to exercise, to read, to spend time with my children, right? That often is the kind of about halfway through when people are discovering they actually have the juice, the drive to want to do stuff, right? That's often on the cusp there. But people, back to the points of the scale, right? It may be different symptoms for different persons. For one, it may be feeling more positive. For another one, it may be, I don't have these terrible thoughts about wanting to die all the time, right? So different spine points on the scale. But on average, when you ask a group of people and compare, do you feel better? Do you feel worse? Is it enough of a difference? Usually at around 3 points on the scale, people say, oh yes, I've noticed something. That's the kind of minimal noticeable difference. So our hope is that if we see on average 4-point improvement, that it may mean 8 points for those who actually getting the treatment biomarker allocated, and that's potentially it may make the difference between feeling well and feeling I can work and feeling depressed for quite a big chunk of the people. So that's why we be cautiously hopeful.
Okay, great. Thank you so much. So Jonathan, if someone in our audience, this question will be for all of you, but I will start with you on this one. So if someone in our audience realizes they themselves or a loved one perhaps are struggling, where is the first place that they should turn? And once they start the journey, how should they navigate that system to find the right match between their needs and treatments like the ones that we have discussed today? So I'll start with you.
Well, and so it's certainly a system where the demand has escalated much more quickly than the supply has been able to keep up with. And so as a result, whether people are in crisis or not, all too often they end up going to the crisis system looking for support. And if there is indeed a crisis going on, that is the appropriate thing. If a person is not in that crisis but does need help, then there are navigation areas like 211 and so on that can at least get a person started looking around for it. But acknowledging it's a challenging issue. I can speak to TMS specifically. There is now the beginnings of a publicly funded system within and a network of hospitals around Ontario, usually in tertiary centers. So most, if it is TMS specifically a person's looking for, then it is available by referral through a GP or through a psychiatrist to the local TMS practice. And filling the gap, there are some private clinics in Canada, and of course, thousands of private clinics in the U.S. as well that people are turning to. So what I would really like to see is this fully integrated within the public system with a well-funded network of clinics all over the place. And so that's what we hopefully will work towards.
Is there a particular place, let's say it's not TMS, that you would suggest or recommend that folks start their journey? So for example, I have no idea where to go. I'm feeling, I have lots of different feelings. Yeah. I'm confused and I don't know where to start.
Yeah, so the 211 resource is certainly one place where people can start the navigation process. Other good resources are the Mood Disorders Association of Ontario also has great resources, and the Canadian Mental Health Association as well.
Okay, great, thank you. And Anne?
If you are struggling, or if you know anyone who's struggling, please know that there is help available for you or for your loved one. Oftentimes, especially for young people, we find that it's intimidating to even disclose the struggle to someone. And it ends up being a crisis later on. So our encouragement is, even if it is like a quiet weight that you're carrying, reach out, ask for help. If the more clinical models or hospitals might feel too cold or intimidating, go to youth wellness hubs. Youth wellness hubs in the city, they have peer support staff. Go to community-based organizations like Loft Community Services. Reach out to us. Look us up on Instagram and see what offerings or programs. If you don't feel like going with one-on-one support, maybe start with a drop-in. You find what is more accessible to you and start with that. Peer support program really is a very valid and important part of the journey. There's peer mentorship. There are peers who can help you navigate. There are peers that could accompany you even to your appointments. They can be an anchor of support, especially when things are feeling hopeless. So please reach out, please connect. There is something for you.
Thank you so much, Anne. And Rudolf, same question to you. If someone's struggling, where's the first place that you think that they should turn to?
Well, the struggling can be different things, right? But if assuming that it's the kind of struggling doesn't go away and that affects the core things in your life, then I think the primary care is a perfect place to start. And for someone who's in university, that may be student health. For many of us, it may be a family practitioner or a drop-in clinic. And for a young person, it may be one of the youth centers. And in most Canadian provinces, there's now direct self-referral system for mental health services. So depending on your area, look up the number, and typically there's the option of self-referral directly to mental health in addition to family doctor referral. but if I think it's good if you have a family doctor for that, for them to be involved, because someone who knows your family can help you coordinate help in a good way. I know not everyone has family doctors.
No, so I was actually
That's why
gonna,
we
yeah,
have all the other options of
exactly.
self-referral.
So we know that lots of folks actually, especially in Ontario and certain provinces in Canada, don't actually have an access to a family doctor. So being able to go to a drop-in or the community health hubs, I think, is an excellent place for folks to start. So with that, I will now turn our attention to you, our audience. I know folks have been sending in their questions, so I want to thank our panelists for their insights up until this point. And we will of course come back to our panelists for a last question or two. Now, of course, wanting to hear from our audience members. So remember, if you haven't sent your questions, please send your questions in. We will share how you can do so on the screens. But I will now start with some of our audience questions. So let's see here. First question. And Rudolf, this will be for you. Does biomarker-based treatments undermine social factors that influence mental health? Or how can these approaches work together to help people? It's an interesting question.
Yeah, it's a good question, and it actually brings in a lot of the, both the history and presence of how mental health, mental illness has been treated, because very often it felt like a divide. Is this nature or nurture, and should we go for therapy versus antidepressants? And I think many people have been harmed by this, this being presented as opposite, right? And I think the data are in it's not either or. It's most people who become unwell because of a mixture of social, environmental, and their genes. And if you take either one of those away, it would have been different. Most people benefit from medication and psychological and social support and treatment, and probably neurostimulation. And those two work beautifully well together. And if we use biomarkers to direct treatment, we are as interested to use them to direct psychological treatment and as we are to direct medication treatment. In fact, one of the studies we're really, really keen on is to inform the decision between initial treatment with psychotherapy and initial treatment with an antidepressant. The two may work well together, but some people may do better starting with one as opposed to the other. And of course, it should, everyone needs a place to live and people to connect with. So I would hate to see any of that bio as being contradictory to the social. And I think the best way of helping everyone live better is to use the resources equally well and in integrated, combined way.
Yeah, I completely agree. Being able to use different treatments and resources in synergy with each other, I'm sure is much more helpful. Jonathan, this is for you. How exactly does TMS work? What are the pulses doing, and what changes are they creating in the brain?
Oh, that's a lovely little question. I'll try and explain it on 3 different levels. And the first one is what the magnetic pulses do. The magnetic pulses pass through the skull, and underneath is the brain tissue. All the little neurons are there. Because the pulse is very powerful and very fast and very focused, when you send it in there, the neurons think that they're actually getting stimulated by other neurons. So they fire, they activate. If you look at somebody in a scanner while that's happening, it's not just the little neurons underneath that are firing. As an example, like let's say you place it over the area of the brain that moves your thumb, and you do a couple of pulses, the person's thumb will actually kind of move like that. Or if you put it over the area that moves the foot and do a couple of pulses, the person's foot will move, and so on. And when you look in a scanner, it's not just the area under the coil, but no brain area is an island. They all work in networks. They have little allies or buddies that they work with to get their jobs done. And when you stimulate one area of the brain, it actually sends little signals to all the other areas, and they all fire together. Every time they fire together, it's a bit like exercise. The neurons that fire together wire together. They strengthen the connections between them, and that network gradually gains in strength and becomes better able to do its function because the areas can communicate more clearly between one another. So the role of the medication that we add on is to boost the brain's natural plasticity mechanisms. Every one of our brains has plasticity. It can rewire itself over time. That's how we recover from strokes. That's how we learn new skills and new languages and new abilities, like in therapy and so on. But that plasticity mechanism of the brain can be amplified a bit with this medication. And if you do that first and you do these pulses, then the strengthening effect, and the sort of exercise that we do, is how TMS works. So its general job is just to rewire and strengthen networks. But what it does for you therapeutically depends on what networks you strengthen. So in Parkinson's disease, where people have tremors, you can actually just place it over the areas of the brain that move thumbs and legs and so on and do stimulation, and the tremor of Parkinson's can be improved that way. In mental health, we tend to go for areas, as I mentioned before, whose real job is resilience. And the funny thing is, when you go and treat somebody who has depression, they'll often come in and say, oh, well, I actually have binge eating disorder as well, and that also cleared up. Or I actually have a bit of OCD, and my OCD seems to be getting better. Or I never mentioned this, but I've been through tremendous amounts of trauma, and I'm noticing a lot of my PTSD is clearing up as well. So you're not just treating the depression. Often we're just kind of generally strengthening this network, which is involved in resilience. And if we can get that to kick in, people tend to come back and say, if it worked for one thing, it usually works for a bunch of stuff.
Right. So it's because of that amazing network of neurons in our brain and all the different pathways, them firing together, working together. Being able to stimulate one set leads to enhancement and improvement in another set.
Yeah, I've done my best. It could be a 500-word book on all of it. There are 500-page books on all of this, but if we want the 30-second version, that's a really great summary.
Awesome. Great. Thank you so much for that, Jonathan. All right. So this one, perhaps a few of our panelists can answer this one. How do I speak with my physician about these newer treatments and wanting to try something different? And I believe this was something that probably came up originally when we were chatting, but yes, a very good question. So how do I speak with my physician about these newer treatments and wanting to try something different? Rudolf, Jonathan?
I'm happy to start. I can see this can be sensitive, right? Because physicians are the experts or like to be the experts. So, and now there's a lot of information out there, right? So you read about things, your family reads about things, suggest like there's something new that may help you. And yeah, but I don't want to ask, because if I ask, it feels like I'm telling my physician that whatever they prescribe me is not the right thing or the new thing. So it is a relationship as well, right? That you have with your care provider, and I think it certainly has been becoming much more common for patients to bring their own suggestions, their family suggestions into the encounter. So I think we all used to it and getting used to it, and sometimes we are challenged how to bring it. I would say respectfully, but also there's also the part, and I want to try something different, right? And I think we often make mistakes on both sides. I find there's some people who you say, well, why have you been taking that same treatment for 5 years if it hasn't worked for you? Shouldn't we have we tried something different, right? And then you see someone, and they seem to have tried 10 different treatments in 6 months. And you need to give it time. It doesn't work from like day to day, except your 1D, right? Generally we need a number of weeks to give it a good try. So I think you can, there's the right rhythm, and I hope in most cases it will be a back and forth conversation with the healthcare provider. So that's.
Yeah, I'm going to be a patient advocate here and say I can tell sometimes it really depends on the physician that you're talking to, right? So the hope is from the patient side is, we as a patient bring in this information with us. Is there any particular language, let's say, and I know, again, this will differ from patient to patient, but what would you be more open to hearing a patient come to you with so that, because of course this is a journey together. And we want patients to feel empowered, to know that they are, they know their bodies. They are coming to you with a specific concern. You have both been working together and you want to try to ensure that, they're feeling better, but the medication has not been working. So from your perspective, what would you be more open to if a patient comes to you with that conversation?
Yeah, I'll do just top of what comes first to my mind. I like to hear directly their experience in as plain language as possible, because sometimes when it feels like a patient is telling me something in words that come from the internet, it feels harder to get through to the information that matters the most. And if it's a new treatment they are interested in, they ask that question early in the consultation, because I think it sometimes becomes harder when it's the kind of end of the hour, leaving the door. And I had this thing to ask about, right? So
especially since patients have such short windows of time to see a physician, so I guess we make that a priority question. But thanks so much.
So that's just a couple of very practical.
I know. I'm pressing on this
plain
question.
language and early on.
Yeah. And Jonathan, any input on that?
Yeah, so I'll tell you one thing that I would love to see in the very first interactions or even a subsequent interaction between a patient and a physician. I think, physicians often in mental health tend to think in terms of algorithms and treatment sequences and this sort of thing. And a conversation that I think sometimes gets missed is the part where we sit down and say, what are your priorities for care? In other words, I'll sit down and I'll say, and I'll often, if a person comes to me and said, well, doc, which one of these things would you try? Like, I actually don't think that's going to be very useful for you, because I have a priority of A, B, and C, whereas your priority might be D, Q, and then A and B. So what I'd really like to hear from you is tell me a little bit about what's the most important thing for you in terms of what treatment we're going to choose next. Are you someone who says, I want this thing gone, I want it as fast as possible, I will spend any amount of money, I'll put my life on hold, I'll do whatever. And you will have people who will say that if it's a family member, if it's an older person, a younger person, they will stop their whole lives to do whatever it takes. You will have other people who come in and say, look, your TMS thing sounds great, but I can't take 5 full days off work for it. I have elderly parents and young kids to look after at the same time. Or you'll say, I'm actually, I've just had a young child and it's tricky for me to come into the hospital, or I live far away. So I think the starting point, before you get into what treatment is the right one for me next, somewhere in there, it's really helpful to sit down with your physician and say, oh, by the way, I want to talk to you about what my priorities of care are. Because when we decide together what treatment we're going to be selecting, I'd like you to know that this is not a huge priority for me. This is a huge priority. Avoiding side effects, this level of priority. Keeping it convenient and safe, this level of priority. So communicating, asking your physician for time and a little space to communicate and go over your priorities of care will help them work and sort of figure out what treatments are going to be in what order for you. So that part's really important. The second part, rightly or wrongly, that I see everybody doing now is everybody's coming into their appointment having had 10 conversations with ChatGPT ahead of time, which is not necessarily a terrible thing, because you can go back and forth and iterate and ask exactly these questions. If you don't feel comfortable, if you don't know quite how to raise this, go and do a little bit of research and see what are the evidence-based treatments. Have that conversation ahead of time where you lay out your priorities of care and go back and forth. And maybe even if you're worried about your physician asking this or that, it's totally fair to go and sort of try out some of these conversations back and forth and say, how do I express this? How do I do that? You only have, to your point, so much time to speak with your physician, so it needs to be efficient. You want to make sure you don't go off where you'll end up conversing about something that's not a high priority for you. I think it's totally fair now that the LLMs have gotten to the point where they are to use the LLMs to fine-tune your conversation and make sure it's like you get to rehearse it 20 times before you go into your medical appointment. You can then go in with a beautiful little tightly focused agenda to make the most of that little time that you have.
Right. So the LLMs like ChatGPT, and then you put your conversation in there. So we heard it up here from.
And just to be clear, I'm not saying that is a substitute for going in. What I'm saying is this is a really great space to have as much time as you want to rehearse that medical encounter and make sure it's about what you want it to be about before you go in there.
Right. Okay, thank you for that. And so, Anne, I will ask you that same question, but from the opposite perspective. Are there specific resources or tools that you share through the community hub perspective to potential patients on how they can go in and have these conversations with physicians?
Absolutely. I think what I'm picking up is how are we listening to our patients or to our clients, and how are we encouraging them to use their voices as informed decision makers in their care, right? And when we talk to our participants, our clients, we have to be able to set up, at least with the way we do culture and comm, for example, we want to make sure there's a setup of infrastructure that really allows feedback and listening. And I think that is where Ontario Brain Institute really helped us. We were able to set up those pulse checks, a focus group for youth, for staff, so that other than just the receiving end, being recipients of care, they become engaged innovators of care. And we find that we want them to bring that same level of voice, of empowerment when they go to the different settings, the different healthcare settings, wherein they could go to your doctor's appointment and these are my priorities. This is what I need right now. These are my focus points. Wherein they don't feel afraid of bringing in some research. Like, hey, I found this. It's interesting. Do you know more about it? Can you tell me more about it? So we want to build that among our clients, specifically the youth, that you use your voice, you have as much right in the determination of your healthcare. Therefore, be curious, bring in what you know, and ask around. And hopefully you would find a collaborator, healthcare provider to help you.
Thanks so much for that, Anne. So I know I belabor that question, but I just thought it's a really, really important question given the realities that we're facing within the province and nationwide. Okay, I'll move us along now. Next question, does mental health impact males and females differently? And if so, how do we address this through the types of care provided, the research questions we ask, and for the development of new treatments? So I know that's a bit of a long question, but first of all, does mental health impact males and females differently? And if so, how? And how do we address it?
If I can do, but I'd love to hear whether the biomarkers you're developing have sort of subtle adjustments that are made depending on whether it's a male or female patient.
Yeah, it's an interesting one. I feel like we should answer the question first, and that, of course, right? And I would say mental health is equally important for males and females, but they are affected in different ways. The classic is, more depression and eating disorders in female, more attention deficit and substance use problems in males. You sum them up, you have equal amount of mental health problems in both sexes and in all genders, but different for sure. The one thing I will point out is men are massively more reluctant to seek help. And the one big discrepancy in mental health is more men die by suicide. And this is probably largely a failure of receiving mental health. support mental health or psychiatric or psychological treatment, and that's the biggest. And what Jonathan asks is very, very important, because of course we're trying to use measurements to optimize treatment, and many of these measurements will look or sound, when it comes to speech, right? For example, different for males and females. The way we do it, because often we end up with relatively complex models, just like you're developing ChatGPT from text, we're developing models to predict which treatment will work from actigraphy and electroencephalography and speech. And in each of these model development, there's a stage when we test whether a sex-specific or gender-specific model actually outperforms a generic model, or whether it needs to be tweaked that way. So yes, it is an important element to incorporate also into the biomarker-based prediction. Overall, most of the signal seems to cut across sex and gender. Most of the predictors, when they work, tend to work irrespective. But that's just an early signal.
Thank you. Jonathan?
So if we're looking at the example of TMS, it's about a 2-to-1 ratio in most studies. There are about twice as many women coming in for TMS as there are for men, just because that roughly reflects the prevalence of depression. It's good to be a woman if you're doing TMS. The odds ratio is about 30% higher that you'll do better on TMS. But I think all of this misses the key point about that some of the biggest differences are just very simple, practical ones. I'll use the example of postpartum depression. The very first grant I ever got to study TMS when I was a young faculty member was actually, could TMS help people in postpartum depression? Great idea. And a year later, it was the only grant I ever gave back, because after a year, we had over 100 people come for TMS, and not one of them was a woman with postpartum depression. In those days, TMS was 6 weeks, Monday to Friday, coming into the clinic. Just not really an option for somebody who has a young child. So with the TMS in those days, back in 2011, we just were not able to do the study, and we gave the funds back. A year ago, this is a more heartwarming story, using the one-day treatment. This was actually a colleague of mine who revealed, after I'd known him for 6 months, that actually my wife has been going through terrible postpartum depression for 2.5 years, and postpartum PTSD, 2 young kids, and really, really struggling. Could we try this one-day thing? So came in on a Saturday, arranged childcare for the day, did the one-day treatment, and over the ensuing weeks, I just kept getting all these calls about, she's doing this for the first time in a year, she's doing that for the first time in a year. She was a psychologist by training, and in the end, a year later, she resumed her career as a psychologist, and she teamed up with a physician and opened a TMS clinic in her town, focused on reproductive life stages and specifically treating women in the same situation. And I was really heartwarmed to hear that she actually used the portable device for a woman who was only 6 weeks postpartum and going through bad depression, and was actually able to bring the device into the person's home and do the treatment for them right there on the spot, so they didn't have to move at all. That was 15 years after that first grant. So, it just takes the point that, technology can do some interesting things, and those interesting things can have benefits in taking people who were previously, and populations who were previously excluded from real access to the treatment. But technology isn't just a fanciness. It actually can allow the technology and the treatments to be more inclusive and bring in people who otherwise would not have access.
Wow, that's amazing. And just to sort of tag on to that and the information that you both shared, which is really sad to hear, of course, that lots of men don't seek treatment, but honestly, I'm not too surprised by that based on the data. And I wanted to ask you about your experience with LOFT, and what have you seen with adolescent males? Do you see more adolescent males or females coming into the community hub for help? And are there specific ways or strategies that you use to, essentially speak with and ensure that the male youth feel comfortable seeking treatment?
Yeah, so whoever comes to the door, especially for young participants or for youth, we try to always bring a trauma-informed approach. And that we know that oftentimes the youth coming to our care had adverse childhood experiences or traumatic experiences when they were younger, thus affecting their mental health. we find that it's possible within the spectrum that it could manifest differently for female or male identifying youth. We also find that there are social hazards that might add to that traumatic experiences, thus adding to mental health. For example, the experience of human trafficking and sexual exploitation for women or for female youth requires a different kind of care and different kind of group support that we also offer within our team. We also find that whenever someone comes to our door, we ask them right away, would you like to work with a female or a male identifying worker? Because we want to be mindful of how that presence or identity would affect their care. Because some would be carrying some fear or trauma. And we're talking about culture too. And part of culture is really looking at it and studying it and asking ourselves, in your culture, are there culturally harming beliefs about male and female? Are there culturally supportive beliefs for male and female? How is that affecting you when you're working with your families, when you're with your community? So we want to take them into consideration. And that's how we tailor our approach. It's very personalized. Because even among female youth, even among male youth, there could be uniqueness. So we want to tailor the approach to them in a way that we communicate with them, we understand where they're coming from. If they say to us, oh, language is important to me, or cultural relevance is important to me, if it's possible, I want to work with somebody who is like my likeness, who I could see myself, then we try to match that as much as possible.
Great. Thank you so much for that, Anne. We've got another really good question here. How can we access these services? And so these services are TMS, I'm sure, and biomarker related treatments. Are they covered by OHIP? Are they covered by insurance? So folks want to know, can they get this? How can they get this? Is it covered? Jonathan,
I
do you
can
want to
go
start?
quickly then. So TMS does have a few centers of excellence in Ontario, and that network is recently to be expanded. So the province does provide some funding for staffing of certain TMS clinics at an increasingly large network of hospitals across Ontario. In addition to that, there's a small but active network of private clinics that are available for people. And as I say, there are some people who just go down to the US and do it there now that it's a quicker treatment. So those are the three main ways that people access TMS at the moment.
Okay. Rudolf?
Well, all treatments that we provide them in hospital settings, and whether they are provided clinically or research-wise, they are always at no cost to patients, and that includes psychotherapy, neurostimulation, and medications. What people get in the clinical trials within CanBind has a level of intensity. So the fact that how much time they spend with us, we spend with them, right? And that we meet, for example, every 2 weeks, that's probably more than what's typically happening in practice. So although all the types of treatments are available for free through public health services, truly, many people tell me, this is the best way to access treatment. I participated in a clinical trial. I feel like I did something good for others, but I feel like I got better treatment than I could have ever gotten. And I think people mean that intensity, the fact that they often are seen within a week of first contacting us, and then we meet every couple of weeks at least. And that's in most provinces not typically accessible unless you privately paying for it. So the time of professionals I see is often the limiting factors to kind of how often you can see someone or how long you wait before you seeing someone. That's not ideal. And in Canadian, unlike US context, that is often the more limiting factor, than the cost is what I'm finding.
Okay, thank you. We've got another one here. Is there a difference between mental health conditions and mental health challenges arising from living with another brain condition like a brain injury? So Rudolf, Jonathan, don't know if either of you wants to start first or...
Sure. So I can say a few words about that. One of the ways in which we were able to, or other researchers were able to develop really great maps of where to target for depression, the so-called depression network, was by a mechanism called causal network mapping. It's a mechanism by which you go and you find surveys of hundreds of people who have suffered brain injuries from stroke or from injuries, wounds. Sometimes they're veterans who've been injured in combat, things like that. And as a result of that, there's some piece of the brain that's been damaged or lesioned. And when that happens, it doesn't just knock out the piece that's missing, but it also affects a whole network of all the areas that are connected to it. So there's no one depression area within the brain or mood regulation area in the brain. But what was interesting is when someone had the idea, a team led by Mike Fox at Harvard had the idea to start looking at the networks that were knocked out. And even though the lesions for people with depression were all over the brain, they tended to fall in the same network. What was interesting was there were also areas anti-correlated to this. There were areas of the brain where if people got lesions in this other network, they would be very unlikely to develop depression, even if they were badly functionally impaired. And then this technique turned out to also work for PTSD. So some people are much more likely to develop PTSD if they have damage in certain regions of the brain. And they're actually extremely unlikely to develop PTSD if they have equally bad damage in other areas of the brain. So, absolutely, there are brain injuries to certain parts of the brain that can damage our capacity for emotion regulation and can make you more likely to develop anxiety, depression, and so on. And weirdly, there are also areas that can be protective about that, even though the injuries themselves can be very disabling. And looking at those as a whole has made it possible to figure out what networks we should be stimulating. That's good news for people with brain injuries when it comes to TMS, because naturally, what kind of treatment should people with brain injury be seeking? Like I say, all four, right? It's if you have a brain injury, you want to be looking at medications, therapies, social supports, and brain stimulation. And the good news is because brain areas work in networks, even if one brain area has been damaged, you can often target another area in the same network. I'll have a very quick anecdote. I had a person who came from Hamilton. He had a freak accident that had caused him to have a damage to one hemisphere of his brain, and it was exactly over the area we normally treat. And he asked us for TMS, and I said, well, it's very unlikely to work because the area we stimulate has been damaged. But he was really, really keen to come. So we ended up putting the coil on the opposite hemisphere of the brain and going through the network just through a different area. And to my surprise, I didn't think it was going to work, but he was really keen. So we did it anyway, and he got a full remission that lasted for, it was very durable. So it is possible in this setting too. Brain stimulation can be part of that set of all four treatments because we now have very good idea about what networks to target.
Wow. Yeah, go ahead, Rudolf.
Yeah. I mean, for the other treatments, it really depends which brain condition. As an example, depression very commonly follows on stroke, but also on neurodegenerative disease, Parkinson's disease, for example. And the answer would be different for the two. In depression that develops after a stroke, the same antidepressant that we use for regular depression unrelated to brain injury seem to be very effective, actually, and beneficial. And sometimes it's been to the detriment that perhaps physicians may be less likely to prescribe because you had a stroke. Whereas in Parkinson's disease, the treatment we would choose for depression is different. Which we need to choose dopaminergic medications such as pramipexole, which is different from the first-line antidepressants. So depending on the type of disease, generally neurodegenerative disease, Parkinson, Alzheimer's disease, and similar change the landscape more profoundly than injury such as stroke or concussion. And the answer will be different, and medication and psychotherapy also play a role.
Okay, thank you so much for that. So we'll take one final question before we wrap up. Another very interesting question here. What are the best things that we can do to build mental health resilience, especially in children and youth? Ooh. Who would like to take that? Do you want to go
I
first?
think I'll
Dan?
start.
Sure. Yeah.
So when we think of children and youth, we're looking at critical time intervention, which means we want to maximize those formative years and those years where we could address if there's any concerns or any issues that are arising. And that could be, again, that would come in a spectrum. It could be, is there a space for healthy socialization where the youth could be equipped or even encouraged to make friends and to learn from conflict, to learn how to navigate conflict or to communicate? Are there spaces wherein perhaps they would benefit with something more of like a skills building group, like what we're doing, the dialectical behavior therapy group, where they attend either to drop in or a close group that they stick with for 10 weeks, and they build on gains. They build on mindfulness. They build on self-soothing techniques. They build on radical acceptance. We also want to give the youth the chance to have meaningful activities where they can contribute. Where can they volunteer? Where can they use their time, their energy, their youthful energy, where they can also learn, but also in the process know that, oh, I do have an impact to others. Oh, I could actually create some change, even some micro changes. We find that when we consider this, of course, along with nourishment, with physical hygiene, with the proper care that they need, and the supports with relationships, the support with opportunities, this really helps the youth's strong mental health.
Great. Thank you so much for sharing that, Anne. Rudolf, Jonathan?
Yeah, I will mention a couple of things because sometimes when we're moving from treatment to prevention, we get surprises, and some well-intentioned initiatives have badly misfired. An example is mindfulness, something that was shown to be effective in preventing further episodes in adults with depression, has been enthusiastically adopted as a preventive method in children, and actually a number of schools in Canada have applied mindfulness programs without evidence. And recently there's been the largest clinical trial of mindfulness in schools completed in the UK. Over 4,000 children randomized by class, by school. And it's not just that it doesn't work, but that the small non-significant effects are in the wrong direction. It may be mildly harmful. So, it doesn't always work like that, that something that feels right will do good. There's many questions around it, why it does not work or why it may be detrimental to some. And of course, there's opportunity cost, right? And there's something that generally the mental health campaigns may do in both adults and children. They focus attention inwardly, right? By talking about mental health when there's wasn't a problem to start with. It may make you focus more attention inward, which means you focusing less outwards. And for most people who are healthy, who don't have a major illness or mental disorder, the best way of spending time is to do something that has a meaning beyond yourself, that reaches out. And I think that's why sometimes the kind of resilience building is not such a straightforward thing. The one thing that generally is coming out really strong in education research is giving autonomy from much earlier age, making your own choices within what's safe, and reaching out beyond your own needs, all that kind of helping others and doing something that has meaning outside of your own entertainment. that seems to be the safest bet.
Okay, thank you both so much for sharing. So I want to say to each of our panelists, we just have about a minute left. So in 30 seconds, it's a big challenge. Please share any final thoughts. What would each of you like for the audience here to take away today? So Jonathan, I'll start with you, 30 seconds.
I think the best way to look at it would be to say this thing called resilience that we've been talking about. There are pathways to find more resilience. We know where the circuits are. There are technologies coming at scale which are going to be able to address them. So alongside the other kinds of therapy we've been hearing about, brain stimulation is going to move into the mainstream. It's going to be available at everybody. It's going to be something we can do for resilience. It's going to be something we can do in a day and coming to a neighborhood near you soon.
Okay, awesome, thank you. Anne?
I look at this room and I see engaged innovators in one way or another. And I think we should always ask, who is invisible here? Whenever we're creating something or when we're redesigning or reimagining a program, who is unheard, underserved, who is being left behind? And I believe that when we ask that question, we could give more voices to more marginalized voices. And together, we could help make the invisible more visible. I think that's true innovation.
Awesome, thank you so much. And Rudolf?
I've been struck how we moved from the latest, technology development, the biomarker discoveries, and adaptations of treatments to the bigger questions, nature, nurture, and what really struck with me was the question about, how do I share with my doctor, that kind of, relationship with potential power imbalance dangers. So that's something that made me think more about, and and actually I think bringing something like this with you may help, and focusing on what's proven, what was there in the guidelines. It's probably the safer bet now. And the good thing about the discoveries that you hear about today is, there's hope for the future. The time scale is a few years, it's not decades.
Awesome. Thank you so much, everyone. So on behalf of the Ontario Brain Institute, I'd like to thank each of our panelists today for sharing their expertise with us. So let's give them a round of applause. And of course, we also want to thank you, the audience, for engaging with this talk tonight. We have some resources to share with you for more information around this topic. We will be posting them on the screen shortly, and a complete list is also available on the OBI website, which is braininstitute.ca. Under resources, you can click on OBI Public Talks, and this will bring you to the Public Talks page. So your feedback is also very valuable to us. So before you rush out, please take a minute to complete the survey. There's a link in the chat box. And for those of you joining us here in the room, you were provided with a printed copy. So please, 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 we appreciate if you share your thoughts with us about tonight's talk. So remember, the feedback that you share helps to improve future events just like this. So your feedback is taken into consideration. So remember that. Please share it with us. OBI talks are designed to share the latest knowledge on brain health and to offer simple tips to manage both health and wellness, as we saw here tonight. And this is the final talk in the Breakthroughs in Brain Science series. We look forward to seeing you again in June when we launch the next OBI public talk series, Neuroplasticity, Past, Present, and Future of Brain Health. Finally, I would like to invite everyone gathered here in person. We're not leaving you out online, but we thank you so much for joining us. But those of you here with us in person, we look forward to seeing you in the reception. So please join us for a reception in the library room to celebrate OBI's 40th public talk. Let's give a round of applause for that. And again, to our online audience, thank you and good night. So good evening to everyone.